Thank you. Thank you for BCNA for inviting me. So I'm going to try and do an overview of what's happening, and please feel free to stop and interrupt and ask questions in the middle whenever. Don't sort of wait till the end. So I guess why do we get cancers? Lots and lots of reasons. We don't really know. Whoever knows will be a multi-billionaire, but we don't really know what happens. But there's lots of reasons that tend to work, and the idea is if you can try and target each one of them, then you can try and attack the cancer from a different way. And I think the problem that tends to, because when we do a biopsy from a breast or a liver or a lung, we sort of say, oh, it's breast cancer, or it's lung cancer, or it's bowel cancers, but even within that same cancer, there could be multiple clones. So you give chemotherapy, you attack some cells, but not the others. And that's why cancer comes back, and that's the problem about having multiple clones. And it's actually been around for a long time. And if some of you like reading books, there's a book called Emperor of All Maladies. It's probably the single best book in terms of looking at history of cancer and what happens. I think radiotherapy came around just before World War II, and this was using implants within the breast. I guess our bits of chemotherapy came around after World War II, where they found nitrogen mustard, and they went back and sort of modified that further into fancier drugs. And I think Herceptin or trastuzumab really was the first targeted biological drug that came along sort of in the late 90s. We got access to it in Australia probably around 2017 or so, but that was our first targeted drug. And I think if you look at the breast, if you look at the top right thing here, the majority of the breast is just fat. A little bit of muscle, there's a lobule that produces milk, and a duct which takes the milk from the lobule to the nipple. That's the breast. So when you think of people who say, I've got ductal carcinoma or IDC, that's invasive ductal carcinoma, which is the cancer of the duct, which is the commonest type of cancer tends to occur. If they talk about lobular cancer, it's the cancer of the lobule. So that's the real difference between the two. There's rarer types that occur, but that's the main things that are there. People talk about DCIS, which is ductal cancer in situ, which is actually not cancer, but it will become cancer at some point. And I think that's the overview of 4 main types. So if the cancer is driven by estrogen, block estrogen. If the cancer is driven by HER2, block the HER2. If triple negative, the only option really is chemotherapy or immunotherapy. But it sort of gives you a sense of what you can use and potentially what the difference might be. So 3 main types driven by estrogen, HER2, or triple negative or basaloid cancers. So most times people figure out because they've either gone to breast screen and get a mammogram done, or they find there's a mass in the breast or the armpit, or they've got a ache or a pain, in the back, or there's something, or they're short of breath. So that's how they pick up something's wrong. They go to their GP or go to a hospital and they try and get sorted out from that respect. So about 5% or so get diagnosed upfront with metastatic disease. And I think there's a fair enough people who have early stage disease, which ends up becoming metastatic down the track. And I think, unfortunately, most times you can't cure the illness once it's stage 4 disease. You can treat it, but you can't get rid of it. So the focus tends to be for disease control, improve survival, and not at the sort of reducing quality of life. So why do we pick what we want? It sort of tends to be, for example, let's say somebody lives far away, there's no point bringing them every week for treatment, or somebody's got, bad neuropathy because they're diabetic, or they've had treatment when they were early stage, so you can't use drugs which affect their fingers again. So you try and pick up why you're going to pick each symptom, or pick each treatment based on that. So if I have to pick 4 main categories, so the first one is driven purely by estrogen. HER2 is negative. The second one is all 3, so estrogen and HER2 positive. The third one is estrogen negative, but HER2 positive. And the last one is triple negative. The ER, it should ideally be OR, but we follow the Americans, that's why it's ER, otherwise it should be OR for estrogen receptor. There's a couple more that have come through now. So there's low HER2, which will be potentially a new class of treatment options available down the track. So when we think of systemic options, we think of chemotherapy, hormone blockade, targeted therapies, and then immune therapy that's sort of coming along now. So some of you might have heard of these drugs or would have had these drugs. It's doxorubicin, epirubicin, which is what people talk about, the red devil, or it's a red colored drug. So of the lot, that's probably the single most potent drug of the lot, but also tends to cause the most grief. There's paclitaxel, there's carbapenem, there's a whole bunch, and the list sort of goes on. I've just picked a few drugs that are there. So if I have to, I'm just going to try and pick main categories of tumor types. So if it's driven by estrogen and HER2 negative, which is sort of the commonest type that's there, we tend to prefer endocrine therapy. There's no need of giving chemo if somebody's got cancer that's driven by estrogen. So I really sort of use chemotherapy either if they've already had lots of treatment with endocrine therapy, or there's bucket load that is in the liver or something else. Otherwise, I wouldn't use chemotherapy. So if somebody's had endocrine therapy for 12 months or longer and has had more cancer on that, that probably is endocrine resistance, or they've had treatment within 6 months of endocrine therapy. So I tend to use organ dysfunction more so. So if somebody's got liver disease, it doesn't mean there's a crisis. It just means that the liver function, if it's a problem, that's when I would use chemo. Otherwise, I wouldn't. In terms of hormone blockage, so tamoxifan's been around forever, 40 years, excellent drug. The middle three are sort of, you can use any one of them. So most people end up using letrozole or exemestane or anastrozole. And then fulvestrant tend to use second line if we have to. So in terms of side effects, most of it is because you're shutting the ovaries down, so you get problems with menopausal symptoms, or the joys of menopause, if you like calling it. So there's hot flushes, there's sweats, there's weight gain, there can be mood changes. Some people complain, so tamoxifen has a higher risk of clots. If somebody's on tamoxifen long term, there's a slightly higher risk of endometrial cancer. So just those things to remember that everything has problems to it, so it's worth thinking about. People on letrozole or on exemestane can also have issues with joint pains, so small joints more than large joints. Osteoporosis can get worse, so worth thinking about. So I think most times first-line therapy tends to be an aromatase inhibitor, which is letrozole or exemestane, along with this class of drugs called CDK4/6 blockers. There really sort of is 3 drugs available in Australia as of now. So there's ribociclib, abemaciclib, or palbociclib. And I think of the lot, we tend to use ribo, is probably the commonest that's there. And each of them have got slightly different side effect profiles. But there's benefit of combining the two. The thing to remember is the aromatase inhibitor is your main drug, not the second one. So even if you had to skip the second one, you still should get the first one ongoing. That's the important bit to remember. For men, I tend to use tamoxifen most times, and it works just as well. And there's nothing that's not funded on Medicare for men as compared to women. So I think it's important to try and avoid testosterone or supplements for men, because that ultimately can transform to estrogen. Now, one of the things with our mutations called ESR1. So majority of people who've been on endocrine therapy, at some point it stops working. And almost 9 times out of 10, it's because of this mutation. So when this mutation, then tamoxifen or letrozole does not work. Fulvestrant probably will work. So it's just worth testing for these at some point of time. So people who have HER2 positive disease. So I tend to use a taxane, which is Abraxane, paclitaxel, whatever you like using it, along with a drug called trastuzumab or Herceptin, a drug called Perjeta or pertuzumab. Once I've done the chemo, I sort of just continue the Herceptin along with the endocrine therapy. This used to be the standard of care second line called Kadcyla, which is interesting in the sense that it's not a chemo drug, it's not Herceptin. They actually take Herceptin with chemo, join it together, and that gets infused. So Herceptin, which is there, that's the thing which is Herceptin. So that's been around, it's off patent, doesn't cost too much. The chemo drug costs nothing. So the reason it's expensive is nothing else but this linker. Just the thing that sticks them together is what makes all the money, that's why they make the money from. It's a linker that causes that cost. But I think as of now, most of us don't tend to use the second line. There's a drug called Enhertu, which is what becomes standard of care now, and we sort of tend to use it for everything now. And I think a lot of that actually got to thank BCNA for, because access to Enhertu sort of came through, convincing people to get onto it and the PBS. So there's significant benefit of using Enhertu. I think it's a good drug in that respect. A lot of people with HER2 ultimately might end up getting brain mets, or if you look for it, they'll actually find this disease there. And I think a lot of the earlier trials actually excluded people from brain mets, but it's an important thing to look for. So I tend to sort of, if possible, cut the brain lesion off. It's 1 or 2 or 3, cut them out. Or we use high-dose radiotherapy to sort of burn those spots off, or you can give whole brain radiotherapy. But the first 2 is ideal if possible. Enhertu is one of an interesting drug that actually goes to the brain and works in the brain area too, which a lot of the other drugs don't. Triple negative is another sort of whole class of disease patterns that's there. It's about sort of 10 to 15% of breast cancers that tend to be. And a lot of times it manifests by disease already in the lungs, the liver, that tends to pick up front. It's worth testing for, if you've got somebody who's 30, 35, because just got diagnosed with triple negative breast cancer in an early stage setting, we must do genetic testing for them. But it's worth testing for a BRCA mutation for them too. We check for something called PDL1, so programmed death ligand. So if somebody's got a PDL1 that's high, they respond better to immune therapy as compared to not. Now we talk about this HER2 low category that is there. Enhertu, or there's another called sacituzumab, might actually work well for HER2 low categories, even though this is triple negative. So again, chemo is really the main option of treatment. So whatever chemo you pick, there's a drug called sacituzumab, which is again a targeted drug. Seems to work well in triple negative, and immune therapy is this new class of drugs that have come through. I tend to use radiotherapy mainly for symptomatic lesions. So if there's a spot in the bone or the lungs, then I also go and zap that out. So SRS and SABR is radiotherapy, just depends on if you do it in the head, in the brain, or the rest of the body. A lot of people complain about disease in the bones. And it's important to treat that, because if somebody breaks a hip or hammers a spine, their mobility gets affected. So it's important to try and fix that early on. So, and I think we should push to get operated, because at least it brings mobility back into action. And I think if somebody's got a fracture, if it's a non-weight bearing thing, I guess you can treat it with radiotherapy. But if it's something which is weight bearing, it should be operated upon. One of the concerns tends to be if the spine gets affected, so the spinal cord can get compressed, that must get treated as an emergency. We tend to use a drug called Zometa or bisphosphonate, which is like Prolia or Xgeva, and that seems to work pretty well. It's important, It's important to get a dental check done. So if somebody is on a bisphosphonate, don't get teeth pulled out, because it can cause lots of issues with the jaw. And it's important to have calcium and vitamin D on a regular basis. So essentially what it's trying to do is taking the calcium from the blood and sticking it on the bones and making the bones stronger. That's primarily what it's trying to do. So genetic testing, there's a few criteria to test for it, and it's probably better to do it through the public sector, because otherwise testing is quite expensive. And they sort of do it fairly often, and they do it quite well. So I tend to refer everyone to the Royal Adelaide, and they'll test for that. In terms of chemotherapy, so you can have immediate, early, or late stage side effects. So if you think of people with nausea, vomiting, this used to be the biggest problem if you go back 10 or 15 or 20 years ago. Very few people ever get sick nowadays, because there's good drugs available, but people can still be queasy, and you can try and prevent that or treat that. The whole idea of doing all this is to prevent side effects. You don't want to treat being nauseous or sick, you want to prevent them. So you use steroids, you use metoclopramide, domperidone. There's a bunch of other drugs available pre-chemo. I tend to use a lot of lorazepam. It works quite well the day before the chemo or on the morning. Olanzapine is a really good drug. So olanzapine is really funded for people who have schizophrenia or bipolar disorder, one of those sort of things, but it's probably the single best drug for nausea. So for those few days that you're all that, you get access to the drug. So it works quite well. We use quite a lot of capecitabine or sacituzumab for chemo, and that can cause diarrhea. And the single most important drug we can use is a drug called loperamide. But usually if somebody's got bad, the best thing is just to stop the chemo tablets, let the gut recover and start back again. People also have neuropathy. So a lot of people who have had chemo in the curative setting have already had paclitaxel or something else. They get some neuropathy when they have stage 4 disease. Then they're getting something similar that can make it worse. So I think it's important to complain about it every single time. You're coming back to the chemo chair like every week or every 2 weeks or 3. Please complain to the nurses, the doctors, because you can reduce the drug, you can stop it, because you can have permanent damage to the fingers and toes. It's important. Be worth using to checking for the mouth in terms of ulcers or stomatitis. So the Peter Mac, which is a hospital up in Melbourne, they actually make a preparation called Peter Mac mouthwash. I found that the single best mouthwash you can get anywhere. And it's not terribly expensive. It's better. It's the same cost as anything else, but for some reason it works better for a lot of my patients.
Sorry, what is it called?
Just Peter Mac mouthwash. It's one of the hospitals in Melbourne at Parkside. So we use bucket loads of steroids with chemo, and they all push the sugars up. So I think it's important to remember for those 2 or 3 days of steroids, your sugars are going to be high. So if you're on insulin, you might have to step it up for 3 days, but bring it down, because then the sugars are going to come back to normal again. If somebody's going to have chemo long term, I think you'd be mad not to have a pick or a port, because it makes no sense to get poked every sort of few days to get bloods, to get everything else. I think it's important to try and get a port unless there's reason. So a lot of time the thing to remember is if you've got a port or a pick, it's a foreign object. This cancer chemotherapy, there's a high chance of getting clots. So if you've got a clot in the leg, I guess that's easy to fix, but if that clot breaks and goes to the lungs, it can kill somebody. So it's important to be on blood. So if somebody is very short of breath, complain, because you need to be on blood thinners. Capecitabine can cause what they call as hand-foot syndrome. So if the fingertips and the toes get really sore or painful, complain, because all you need to do is stop the tablets and it fixes itself. We talk about immune therapy. Now, immune therapy sort of came along about a decade or so ago. And it sort of completely transformed the way we treat melanomas and lung cancers and head and neck cancers. But it wasn't as phenomenal in breast cancer. That's why it hasn't sort of picked up as much of data as it has in terms of other cancer types. So that's sort of a bit of a cartoon of what I think it works. So if you look at the top bit of the thing, so the big one is the T cell, which is our immune system. And the other one is like a healthy cell or infected cell. So the T cell recognizes the bad thing and kills that cell off. That's the way it should normally happen, but the healthy cell doesn't get affected. If you go down to the lower part, so you've still got that T cell there, the cancer cell somehow manages to evade the immune system. That's why it keeps growing. If you can somehow activate the immune system, which is these class of drugs, so there's nivolumab, all the immune therapy drugs, the checkpoint inhibitor, then it activates the immune system and fights the cancer. That's the whole logic of giving immune therapy. So I guess some of the concerns we have in terms of long-term treatment is people have had doxorubicin or Herceptin. It can cause heart failure. So it's important to do heart scans sort of every few months. A lot of people end up getting surgery done in the armpit, radiotherapy. It can cause lymphedema. I guess for men with breast cancer, again, there's access to drugs available. For people who live far away, I think it's important to remember about, shuttling back and forth. I guess not so much for Murray Bridge. For people who live further away, the PATS form is important, because if you're 100 kilometers and more, at least you can get sort of some help for transport. If you're having radiotherapy, let's say at the Royal Adelaide or a Genesis Care up at St Andrews, Cancer Council Lodge is excellent. So it's, those things are worth remembering. And I think it's also important to remember to have some sort of system of having support groups. And I think a lot of times, I think the Migrant nurses sort of support most people, but I think otherwise it gets quite hard for people who live in isolation. I tend to encourage people to work while they're still on treatment, but it's completely up to the person they want to work or not. I'm happy to sign off. They don't need to work. They're happy to say that they can work. So whatever makes you happy, I'm happy to do that. Because I think if you just sit at home, do nothing, you just drive yourself mad and drive the family mad. So I think it's good to sort of do something. So I think for a lot of the patients on treatment, I think the nursing support in the day center is excellent. So there's access to them through phone services or whatever else. And I think the idea is for a lot of the people is to avoid the emergency department so they can try and see a direct admission into the hospital. We've got counseling services available, and I think in terms of support to this canteen for the kids, there's McGrath Foundation nurses are there, there's BCNA. So there's a whole bunch of resources available. I think it's important to complain about symptoms, not because you're whinging, but because you can at least try and do something about it. So there's no reason to live in pain. You know, if you've got pain, complain and get something for pain. Alopecia can be prevented if possible by using cold caps. But I think for people who can't prevent it, remember a lot of the places will have vouchers for wigs, so it's worth using those. Contraception becomes a harder issue. I've just got a lady who's got advanced disease and she didn't tell anyone but then got pregnant. She just delivered her baby on Monday, but she got metastatic disease, so it's a bit of a nightmare once that happens because I couldn't treat her. So there's a huge issue with psychological impacts. So it's important to try and recognize an issue with anxiety, with depression, and you can try and fix that. Like, for example, Charlotte just gave a talk. She's excellent. I think those are people worth getting access to in terms of trying to help and support yourself and the family. I think the GP still remains the primary focus, and everyone sort of works around the GP. I've just found it interesting because most times people will call me up for, can I do a script for blood pressure? Can I do a script for this? Because they can't get into the GP. But I sort of become the GP and everything else. But I think the GP still remains your primary focus. The community palliative care supports are excellent. Now, I think when I tell people or they sort of feel I'm going to die imminently, that's not the case. You can get lots more support through the palliative care team. The community, so there's public and there's private. For people who live close to town, I guess Calvary has a good community palliative care services, but for the majority of the people around the state, the community palliative care is absolutely excellent. And most of it tends to be community nurses, and they do a very good job. I think it's important to have goals, short-term, long-term, and try and work through each one of them. I've got a few patients whose all their goals is, I'm going for that cruise, I'm going for that cruise, I'm going for that holiday. So you sort of try and work the appointments between their holidays. But that's important because that's what matters to her. So some of us doctors got together a couple of years ago and set up a research unit up on South Terrace. And that's sort of mainly to try and sort of see if we can get access to completely different class of drugs. And I think for us, it was more about getting cutting edge data or cutting edge drugs. So there really is no cost because all the studies get covered through the studies that are there. And it's sort of public and private patients. There's really no thing about it's only for private patients. So we sort of based up on South Terrace, this fancy new building that sort of came along, so we're in the top of that. So a lot of it is phase 2 and phase 3 work, but a lot of it is also phase 1. So what that means is if you think of you've got a new molecule, you move it on dogs and cats and rats, and you're moving to humans now, so that's first in human studies, so we've got access to those. Then that is phase 1, then goes on beyond. I think what's important is these are drugs that even if you had the cash, you physically can't buy these drugs from anywhere. So you get access to completely new drugs. We've just set up a study for metastatic, first-line metastatic breast cancer studies for somebody who lives far away, let's say in Port Lincoln or Mount Gambier, so we can do a telemedicine collaboration for them. So they've got nurses at each of these sites, so 4 sites, so Port Lincoln, Mount Gambier, Viola, and Berry. So we video link in with the nurse there and the patients come along and then we can treat them based on that. So just give a sense of what is, so for example, there's a study called Veritech. So this is if somebody's been diagnosed with ER, estrogen receptor positive disease, they get access to completely new class. Like, you think of letrozole, which is aromatase inhibitors. You think of CDK4/6. So this gets access to a completely new class called CAT6 blockers, just a new class of drugs. So you combine them together and get access to that. So for people who are on letrozole or ribociclib, whatever else, and there's more disease then, which is probably an ESR1 mutation, so you can get access to a study called OLIMA. We get access to a whole new class of drugs. So these are called CERAN blockers, so new drugs that are there. Another study called OPERA. This is a phase 1, the 4/5. It doesn't actually have a name, it's got a number to the drug. But these are for people who've had endocrine therapy, chemotherapy, like 4 or 5 or 6 different lines of treatment. You can still go on to endocrine therapy. It's a completely new class of drugs that are there. So there's a lot of women, not a lot, but there'll be some women who would have ER-positive disease, but there'll also have a mutation called PIK3CA. This is a mutation that's there. A lot of these things can be tested through what they call as NGS, next generation sequencing. So people who are on treatment, it's worth asking your oncologist, can I do an NGS testing on my latest biopsy or something else? Because something's driving the cancer. And if you can find out what's driving the cancer, you can then go and target that. So on this, if somebody has a mutation, then we can get access to this drug which blocks that off. There's a class of mutations called KRAS G12C, which is classically seen in bowel and in lung cancers. But then now they're finding that it doesn't matter where the cancer is. If the mutation is present, it works on everything. Similarly, people who have HER2-positive disease, so we use Herceptin and Perjeta, but there's a class of drugs called tucatinib, so you can get access to that through this study. People who have triple-negative breast cancers, there's sort of a whole bunch of drugs available, so this gives access to immune therapy, doublet immune therapy, targeted immune therapy, so there's a whole extra class of drugs that are there. Then we've also got a whole bunch of studies which is for, doesn't matter which cancer type it is, whether it's breast or lung or bowel, they can get access to one of these therapies through that. So you do a biopsy, test it out, and then you can treat them based on that. We also, I don't know if it's still open, so we actually, if somebody's on treatment for a long time, you can do a fresh biopsy on them. That gets sent off, you actually convert that into a vaccine, and then you inject the person. It takes about 3 months to do it. So somebody's got to be, let's say somebody's on, I don't know, Herceptin or immunotherapy for a long time. They're doing quite well, do a biopsy, create a vaccine, and when they need it, they can go on to this vaccine therapy. So they don't need chemo, just vaccine alone. We've got a study called Suplexa, which is using, you draw a person's blood, you separate out the immune cells out of that, multiply the immune cells, enhance them, and put them back into the person. And the body's immune cells should automatically work. So that's the whole concept of doing it. Anyway, just saying there's lots of stuff available. I guess.
When you're just talking about the vaccine, how you said that you need to be on it long term. How long do you class as long term?
Oh no, I don't think it's a question of long term, but I think it's more trying to say that if somebody's got actively growing cancer, they don't have the time to sit and wait to go onto a vaccine. But if somebody's on, let's say, endocrine therapy, or they're on immune therapy or whatever else, and they've got stable disease, which means nothing's going to happen to them imminently, they can do a biopsy, create a vaccine, and then down the track, if required, you can use it then. It's those things that's trying to look at. Not because somebody's on it for 2 years or 5 years.
Yeah, well, that's what I was kind of thinking, because I was on Herceptin for about 18 months, and then my body stopped responding to that. But on that time when I was responding to Herceptin, that's when obviously my disease was stable. And is that what you would class as a long-term?
Correct.
Yeah, okay.
So thank you for your time. And I think BCNA has got lots of resources on their website, so it's worth sort of looking at that and sort of seeing what you can get, what you can benefit of that. Thank you.
Thanks so much, Rohit. We do have time for questions, comments, discussion points. Any of our breast care nurses, do you have any comments or questions? Dev, I'm going to put you on the spot. Any question or comments? No?
Hi, my name is Rose. I've had breast cancer and bowel cancer, fairly bad ones, and have survived. Question when you were talking about the doxorubicin and Herceptin. In terms of how often should you get your heart checked? Because I've never had it done. No one's ever mentioned that to me. And I've had scans for CT scans and stuff, and I've got opaqueness and scarring and all of that. I was told that I wouldn't have any symptoms if I was generally well for about 20 years until I got older. Is that the case?
A lot of us tend to do a heart scan prior to doxorubicin as a baseline.
Yep.
If the baseline scan is good, there's probably no need to repeat one. If somebody's on Herceptin or HER2, one of these sort of drugs, we tend to do it a baseline. We sort of do it every sort of 3 or 4 months because it can affect the heart at some point.
Yeah.
So the difference is that, so for example, doxorubicin, epirubicin can potentially cause irreversible heart damage. Herceptin tends to cause a reversal. So you stop it, it'll bounce back, the heart will bounce back.
I've had half of the drugs that you've got up there, so with actually no side effects.
You're just weird.
I'm one of those special weird people, is how he said it, yeah. But I did get lots of neuropathy, and the one thing I would say is if you are having treatment, and this is something I think they just forget to tell you about the neuropathy, they didn't say anything to me about it. So I just assumed, it was one of the normal side effects. I didn't realise that if I got it, how bad it would be, and that I suffer with it on and off, changes every day. So it's ongoing, yeah. That was one thing I would say to ask that question if you're supporting anyone, because they just don't mention it, and it's the one thing that's caused me the biggest issues.
So there are people who, how people use cold caps for preserving hair on the head.
I use that.
So people can also use gloves sort of to do it, or they can get socks to sort of do it. But invariably what I found is for people is when 20 minutes they want to, scratch their nose or something, and they'll take it off and they'll sort of do something with it, or they'll eat something, or they want to walk to the loo. So practically doesn't work as well, the frozen gloves. But it's an issue because you end up getting, let's say, paclitaxel early stage. You probably will get Abraxane later stage. Sacituzumab, vinorelbine, they all affect the nerves. Yeah. Cisplatin, so they all cause. So I think that's a problem. It's something worth complaining each time.
Yeah. Lovely, thank you.
Just going back to the question though, if there wasn't a baseline test done, would it be of benefit to get tests done now to get a picture of whether there's been impact to the heart or not?
What are you going to do?
Yeah, good question.
It's actually of a scan. It's not just your ECG. It's a proper scan, an echo, and all of that.
Yeah. So there's 2 ways to test for heart. So one is an echocardiogram, which is sort of gives you a good thing. The other thing is what they call as a gated blood pool scan. So that's like a bone scan, but for the heart, an ultrasound of the heart that just looks at the muscle function of the heart.
Okay. So if I've got a perfect ECG, chances are that I'm okay?
Suspect so.
Thank you.
Thanks.
I'm loading.
Oh, okay. No worries.
Sorry, when you brought up about triple negative, and you were saying about you going to get tested and all of that kind of stuff. I've got a 16-year-old daughter. I'm HER2 positive, so I'm triple positive. Is there any benefit in her getting tested, because it's not a hereditary thing that I've obviously got going on? It's the gene mutation. It's whatever cell mutation. Would you recommend testing for that?
So I think the way that I see it is for testing people, genetic testing for BRCA1, BRCA2, PALC, check all of these things. Anyone under the age of 45, triple negative cancers who are early, any man with breast cancer, anyone with bilateral breast cancers, anyone with 2 first relatives with breast or ovarian cancer, history of BRCA mutation. Like if you've got this sort of 6 or 7 different things, you should get tested. If you don't fit into these categories, the chances of having mutation is pretty low. And it makes little sense to test for the other family members if the person with the cancer is not positive, like doesn't have the mutation. So unless you have the mutation, there's no point testing for your daughter.
That's kind of what I thought, but it's worth asking the question.
But also, I think the thing to remember is when we're doing all these fancy testing, it should be of speaking to a genetic counselor, because the implications of these things is quite significant. So, for example, let's say you've got a mutation. You've got two daughters. One wants to know, one doesn't want to know. What do you do then? For that matter, what happens to the insurance down the track? What happens to the fear of something's going to happen to me down? Like all those things matter. So I think it's important to test that out. So I think Australia, thankfully, has a thing that if somebody has a mutation, they can't get impacted with Medicare and all those things. It doesn't make a difference. But like in other countries where the insurance is dependent on the problem, it's a huge issue.
Is something that we're actually advocating for at the moment and working closely with a group where there has been discrimination against insurance, and we're starting to see it play out in private health insurance where people around the country in pockets have been declined cover because they have identified as a BRCA mutated, so that we are starting to see that play out. So there's a group of us that are advocating strongly for legislative change. We've got support on both sides of government, but and it's being led by a girl called Jane Tiller from Monash University, and a number of us advocacy groups are working really hard to have it legislated, because the more genomics and genetic testing and the more we learn and we know and precision medicine evolves, and the more treatments we can actually tailor to people's subtype of breast cancer, it's going to become, normal practice to understand someone's genetic makeup, and to be discriminated against is just not where we want to be in this country. So it's a big advocacy piece. So watch this space through our news items and online.
The other thing is that when we think of BRCA mutation, we always think of it's a lady's problem. Actually, it's not. So 15-20% of all men with prostate cancer will be BRCA mutant. A lot of the pancreatic cancers are BRCA mutant. So it's not gastric cancers. So there's not just breast and ovary. There's lots of other things also happening.
When do you suggest doing the genetic testing? Like, is there a time frame you need to?
So let's say you've got somebody, let's say you've got a 35-year-old lady with triple negative breast cancer early stage. So she's going to have neoadjuvant chemotherapy up front. So when they're diagnosed, we sort of send them off to genetics testing, because it takes about 2 or 3 months to get the results, or longer. So by the time she's ready for surgery, we'll have the results. So if she has a mutation present, then probably best to do a mastectomy as compared to a lumpectomy or a bilateral mesh. So that way you can at least plan what to do for surgery upfront as compared to getting a second procedure done. Yeah, so I think again it depends if they've got a BRCA, like they've got a high risk other 6 or 7 categories. If they're, it'll still be the same story. They'll end up, so most of them will end up getting surgery up front, because I think if somebody's cancer is driven by estrogen, surgery is still the best option. Give chemo or endocrine therapy later. You would test for them around the time of surgery. If they end up getting chemotherapy, you'll get the answer down the track, and they may end up getting a second surgery later. So that may not be the BRCA testing. That might be Oncotype DX. Yeah. So Oncotype DX is more if somebody's got estrogen receptor positive disease, which is node negative. What's the benefit of chemo? So you can create a score. So that sort of mainly goes to the US. I think it's about $5,000 and a bit now for testing it. But I've almost never sent it. I think I've sent it once or twice to somebody who just sort of drove me mad. So I said, just spend the money and do it, because I didn't know what else to do, because I couldn't convince them one way or the other. So I said, get the testing done. But I don't sort of tend to do it very often. It's quite expensive, and the actual benefit is relatively little, which is why it's not MBS funded. If the benefit was there, I'm sure it'll be funded by the government. So that's the way I see it. But in terms of the BRCA mutation or these mutation testing, that's usually a germline issue, which means that it's never going to change. So if somebody had it, I don't know, when they're 20, they'll also have it when they're 40 in terms of mutation. What you're talking about potentially after lots of treatment is that can the cancer mutate? Yes, it can. So about 30% of all breast cancers which are driven by estrogen will actually convert to a triple negative. 30%, that's a very, very high number. So it's important to, when somebody has cancer recurrence, it's important to biopsy it.
I was just wondering about the epigenetics effect of all the drugs and all the,
Well, if you use organic vegan chemo, it doesn't affect the thing.
Just to touch on EndoPredict, so another test similar to Oncotype. So Breast Cancer Network have been advocating for probably the best part of 10 years to try and get one of those tests reimbursed through MSAC, which is the medical element. So what that means is Medicare. So instead of not being through pharma, through the PBAC, but through Medicare, and they've just approved EndoPredict, so it's still an out-of-pocket cost for many people. We're just trying to negotiate with them at the moment to try and get that price a little bit lower. But that is something that we've been working on. It's been really tricky to try and get those tests reimbursed by government. It's been a long advocacy piece for us. Any other questions? Comments? No? Well, please join me in thanking Rohit Joshi, who came away from his clinic to be with us today. So thank you so much.